Hello, everyone. Welcome back from lunch. We need to get the show on the road. It is a very distinct pleasure to introduce our next speaker. It's difficult to adequately describe the accomplishments of Dr. van Ingen in what is a very, very short period of time. Jakko, are you in your 30s? Okay. Yeah. Jakko's output surpassed mine quite some time ago. He is just incredibly prolific. His contributions are extremely important and influential. It is just, as I say, it is just such a pleasure to introduce him, and we're very lucky to have him here today. He's going to talk about the role of the laboratory. Dr. van Ingen.
Thanks a lot. It's a tremendous pleasure to be here. I mean, this is only my second NTMir conference, and I'll tell you a fun story about the first one later on. And I walked into the room this morning, and it had, Survivor playing Eye of the Tiger. I thought I was apt for like, yeah, let's go. I play drums in a punk rock band, so I like the upbeat stuff. And these meetings have always, well, at least the ones I've visited, have always been really upbeat and really, really inspiring meetings. And before I start my talk, I just want to share a fun story. I mean, the first NTMir meeting I went to was in San Diego. At UCSD, so I took a public bus. It was kind of difficult to figure out how to do that, but I did. And then I wanted to go back by bus, and I don't know if the girls are still here in the room, but I was grabbed by two people in the room that, listen, you are not traveling by bus. So they pushed me into their rental car. We're going to take you home wherever you're staying. And so, that's kind of the atmosphere of this meeting. I'll never forget that. That was really good. So yeah, I was hired for my age. I'm here to lower the mean age. And in the Netherlands, I'm hired to run the National Reference Lab for NTM. And we do that from the city of Nijmegen, which is on the German border. So this is, as you can see, this is the center that we work in. This is where our patients are admitted. It's a classic TB sanatorium, has been in operation for over a century. And this is where we have our multidisciplinary team meetings with pulmonologists, ID docs, pharmacists, radiologists, and clinical microbiologists like myself. So in the Netherlands, that's a medical specialty. And apart from running the clinical lab, I also run an NTM research lab focused on finding new drugs or repurposing existing drugs that could be helpful in treating NTM, a pulmonary disease. So I know it's just, after lunch, so I thought, let's just not raise the bar too high. So I really hope that what you can take away from this is what we do in the lab to help your clinicians is helping them establish the diagnosis, right? By detecting the NTM, identifying them properly. We do drug susceptibility testing, hoping that that will help to treat everyone with the best possible regimen. And we monitor the effect of treatment. And, doing all those repetitive cultures, and I'm sure a lot of you have, sometimes been waiting for these results, like, oh, is my culture going to be positive or negative? And I can assure you that is true in the lab as well. My staff, my technicians in the lab, because, all our patients are with us for such a long time, they know who they are, and they occasionally come with me to rounds in clinic, so they actually meet the patients. So they are also very personally attached to your cultures. So sometimes, they call me like, oh, you're not going to believe it. This lady, Miss X, is culture positive again. She was negative 2 times. So even though you may never meet these people, but a lot of people are emotionally driven, to have you have the right diagnosis, but also are with you on that journey during treatment. You'll never see them, but a lot of people are with you on your journey. So detection and identification, and a lot of this has already been said. That's why I got the easy spot after lunch. So that starts with the really basic thing, you know, having the sample come into the lab. And the first thing we do is just have a look. Like, nah, this is more like saliva. And then we call your pulmonary physician, and we're like, yo, that ain't good. You know, we have to get a new one. And we're lucky, we're in a tiny country. You know, even if patients live on the other side of the country, that's typically a 1.5-hour drive. Yeah, I mean, that's what it is. So sometimes when we call too late and, you know, the patient's already gone, we can still call them in their car. They can turn around and come back. That has happened. So that's easy to do in a small country. So that's the first thing we do. And then, you know, we start doing our lab stuff. Decontamination. Make sure that all, you know, the normal oral bacteria are dead by the time we start the cultures. And just to keep you activated, how many of you have ever gotten into your doctor's office and then the doctor says, your last culture came back contaminated? Good for you. It's, you know, it stinks. You're like, contaminated. It's not a yes, not a no. It's a nothing. But it is, in fact, important. Some of your cultures have to be contaminated. And that sounds weird, but remember, if the lab is too aggressive in trying to kill all your, you know, your oral bacteria, they will also kill the NTM. So they'll do the cultures, and they'll come back negative, and you'll be, yay! But it's not actually true. So a contaminated culture every once in a while is a blessing. It means your lab is doing a good job. So it sounds bad, but it's actually good. And it's something that your lab also monitors. It's part of quality control. You know, sometimes you have to have contaminated cultures, just not too much, because that means that you're not doing a good job at that decontamination process of cleaning the sputum of the oral bacteria. And then what we do, and that has also been mentioned a lot today, is the smear. Incredibly important. As you've heard this morning, a positive smear means a lot. It means a lot of bacteria are present, could be live or dead, but it also means a lot in terms of prognosis. And that's really, really important. And well, I hope you can see it on the slide. There's a picture of how we do that. So this is an auramine stain. So it's fluorescence microscopy. So our technicians look at a black background, and the microbacteria come up flashing yellow to green, depending on what color you use. So it's fluorescent. So it's really nice, and really nice to see. And I showed this to pulmonologists in training just a few weeks ago, and they thought it was a work of modern art by Mr. Fontana. And I said, no, it's not a Fontana work. It's, you see, and that was also alluded to this morning. Physicians do not routinely visit the lab, and it is worthwhile. Well, I would say if only to smell abscesses once, if you smelled that once. But that's another thing. The other thing that we do, and that's not routine, is we screen for the presence of NTM using PCRs. So we're looking for DNA of NTM. What that means, I don't know. But hey, are you ever going to find out if you don't try it? No. So that's why we do it. And sometimes it's really helpful. Because if the smear is positive, the PCR is positive, you sequence it, and 3 days later, you know, it's avium, or it's Kansasii, you know, maybe you don't have to wait for that culture to flag positive 2 weeks later. Sometimes it's helpful, but we're still working on that. But of course, and, you know, this is what has been discussed so much this morning, you know, those cultures, the long wait. You know, you all want them to be negative. The lab takes 8 weeks to call it a negative. I mean, you know, we look at it for 8 weeks, like, please let it be negative. And only after 8 weeks, we clear it, say, okay, it's negative. So culture is typically 2 things. Liquid culture, sometimes called broth. And you can see the photos in the upper left. It's bottles with a liquid or tubes, and if they get positive and you shake them, you can see the mycobacteria form these sort of clouds and then slowly fall down. They are clumpy bacteria. They stick to each other, and those clumps you can see in the broth. And then you're sure, okay, there's growth, and now we have to see what it is. And there's also solid medium, and the classic is the Lowenstein-Jensen. And the only nice thing to know about that medium is that it's made of eggs, potatoes, and tomatoes. Isn't that nice? You could make it in your own home. Actually, you can. And culture is just so important. That's really at the core of what we do, both in terms of getting the diagnosis as well as following up the effect of treatment. And you can do that qualitatively, saying, okay, the culture is positive or culture is negative, but what we are also highly interested in is quantitative assessment. So how many live bacteria were there in your sputum? And is that less than it was a month ago, 3 months ago? Of course, that's what we all hope for. And we know, and well, Dr. Griffith has done, I think, the best study to date to show that that might actually predict where you're going in terms of response to treatment. So if the number of bacteria is going down early in treatment, chances are good that you're going to convert to negative cultures. So that's culture. Okay, and I'm terribly sorry. This lab stuff is also boring. But we go down to identification, and this also has been covered this morning. I mean, this is critically important. It matters so much which species you culture. Some are definitely pathogenic. Some are definitely not. So it's really important for the lab, if a culture flags positive, to know what it is and to be very exact about it. And I think this morning, Rachel Thompson showed that it's also important to know whether it's Mycobacterium avium or intracellulare. In thinking about where does this come from. Perhaps also prognosis. How likely is treatment going to be successful? That, in my opinion, is also different between avium and intracellulare, at least in our setting. But that's very different in different areas. So how do we do that? How do we give the mycobacterium its right name? Typically by looking at its DNA. Sequencing parts of its DNA, or what we currently do, sequence the entire DNA. And then say, this is what it is. This is Mycobacterium abscessus, subspecies abscessus, or Mycobacterium avium. The other way to do it, which is relatively new in the lab, and I know this is getting picked up more and more, is to use MALDI-TOF, which I always compare to squashing tomatoes. You take a tomato, you just smash it, and then you look at, okay, is there a lot of fluid coming out? How big are the seeds? What color is it? And you kind of know what type of tomato it was. That's how MALDI-TOF works. You crack the bacteria open, you look at their contents, you're like, okay, judging from all the pieces of the puzzle, it must have been avium that I cracked. That's how it works. And that's used increasingly in labs, and it's becoming a better and better method of identification. And for a lot of centers that in the past could not go beyond MAC, this offers an opportunity to see, is this avium or intracellulare? And I mean, these systems are becoming better and better at doing that. So why then is that name so important? Well, I already alluded to that, and that's, so this is the central part of my PhD thesis, which I finished 10 years ago on NTM. So, 4 years of hard work, and it all comes down to drawing this picture. It took me like 5 minutes on the train to a meeting where I had to present some stuff to try and get funding, which of course I didn't get. But this figure kind of stuck with me. And it's just a visual scale. It's, this is what we found in the Netherlands, looking at pulmonary NTM isolates of different species. We went back to all the medical records of the affected patients. So we looked, did they meet diagnostic criteria or not? And we found that the percentage of patients that did meet diagnostic criteria was so different between the different NTM species. So yes, it does matter whether you find Mycobacterium avium or Mycobacterium fortuitum, as Dr. Griffith also told this morning, it does matter. So drug susceptibility testing then. That's the most complicated topic. And you know, I'm best known for being obnoxious and annoying, and also because I think very different about drug susceptibility testing than most. I'm a bigger fan of it than many. So as a general rule, of course, you should only do drug susceptibility testing for drugs that are available. You should only do it for patients who need to be treated with the drugs or who are very, very likely to need treatment with the drugs. And you only test for drugs for which you know that what you're going to find is actually helpful to the treating physicians. It will actually predict the likelihood of treatment success. I mean, if the susceptibility in the lab does not predict what's going to happen in treatment, why test? You know, it's not going to help anyone. And you should also only test if you know that over time differences can occur. For example, resistance can develop. And for some drugs, we're still not too sure how that actually works. So those are the basic criteria. And then how to do it, I'll make mini microbiologists of all of you now. You can look at the slides and you'll figure it out. This is a method that I can say Richard Wallace and Barbara Brown-Elliott sort of invented. It's fantastic. We use it all the time. And it's as simple as it gets. You take a drug in ever increasing concentrations, you throw it onto the bacteria, you know, and each tube has a different concentration, and you just look, okay, it's alive, 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 dead. And then you look, okay, so the concentration where the bacteria are dead, that's what we call the MIC, so the minimum inhibitory concentration. And then we have guidelines to tell us, okay, but how should we interpret that? If the MIC is concentration X, do we call that susceptible or resistant? And that's, of course, where a lot of really, really important work, again, by Richard Wallace and Barbara Brown-Elliott comes in, because they essentially wrote the rules. And I don't agree with all of them. Most of them are fantastic. I don't agree with all of them. Did I say that? There's some more work to do, but at least this is what we have. And for key drugs, like macrolides, like amikacin, we know what we're measuring, and we know what it means. And I think the recent CONVERT trial confirmed that. But there's another way of looking at this. And that's something a lot more complicated. And I really hope that this will finally make it into the world of NTM. And that's looking at susceptibility and resistance really from the patient perspective. From, okay, if you take this drug, how much of the drug will actually make it into your lungs, into where the infection is? And how does that predict whether it's going to work or not? So what if you change the dose? Will it work better or not? So that is something that, strangely enough, has never been done well in NTM. I mean, it's applied all over microbiology. It's just in TB, people have been hesitant for a long time, and in NTM, it's just been, well, I would almost say frowned upon. But I think this will really change what we do, and it will definitely change how we look at the new drugs that are coming, hopefully, and see, okay, if this drug can get to the lungs in this concentration, is it going to work or not? And so there are models in the laboratory that you can use to test that without having to go into animals, and even better, without just having to give it to patients not knowing what you're doing. And that, sadly, has been a lot of the history of treatment of NTM disease. Just try, okay, in the lab, this drug sort of looks good, so let's go for it. So there's more interesting models now coming that will really help us to tease out, will this drug work at doses that are actually safe for use? So this is something that, from a research perspective, I'm really enthusiastic about. And the guy who's pointed out with an arrow is Mike Ruth, one of our PhD students, who's building that hollow fiber model and who's doing really crazy work. It's really complicated, but in the end, it has already shown us something fascinating, that for some MAC strains, an old drug, minocycline, could work if the MIC is low enough and we can use standard doses of that drug. Sadly, these are just models. And I have to tell you, of the many stupid things I've done in my life, and we could have a conference on that anyway, one of them was published data from this model looking at a Mycobacterium abscessus drug called tigecycline. And we found that to optimize its efficacy, the daily dose should really be doubled. Now, we published that as sort of a scientific finding, like, look, if you could use double the dose, it would be a lot more effective. And then I got spanked by Chuck Daly, who then had a patient come into clinic who had been treated by his referring physician with that higher dose, and had terrible, terrible adverse events. And I still feel that I'm to blame for that. And Chuck still also feels that. He doesn't say it, but he also feels that I'm to blame for that. And I take the blame for that. And that's one thing. These models are fascinating. I think they will really guide us to use particular drugs, but they are models. The macrophages in those models do not complicate, they don't tell, oh, I'm feeling nausea, headaches. They don't have adverse events. So that's just what they are. But I think they will transform the way we look at antimicrobacterial drugs for NTM. Now, the abscessus and macrolide story has been fully covered by Dr. Daly, and so I'll skip that for now with Urumgene and all. And I'll end to again touch upon monitoring of treatment efficacy. And that's something that we do in the lab. And as I told you, that's something that we are very emotional about, because we know what it means when cultures turn positive again, or when we culture a new bug, when we culture abscesses in someone who had been on treatment for avium. That's sad, but that's what we do. And so we do that, looking at how many live bacteria are there. So the time to culture positivity is a measure of how many live bacteria are there. And of course, we look at culture conversion. Is the culture negative on treatment or still positive? And the last part of that is something that we're currently developing, and on basis, again, of brilliant work by Richard Wallace, looking at DNA fingerprinting. If we culture MAC again, is it the same species again? Is it again avium? And is it the same strain? Or is this a new infection? And that's incredibly relevant. And that's something that I think should be routine in all microbacteriology labs. But because of the complicated techniques that you need to do it, sadly, it's not yet. We are currently applying whole genome sequencing for this, and that works. And there's a couple of centers here in the US that do that too. And I think that's really where we need to go. And that also teaches us a lot about how the bacteria mutate in relation to being exposed to all those antibiotics, so how they become more resistant. And that's something that we're learning from these same sequencing approaches. So I hope I have convinced you, I feel this is some kind of a public relations talk here, that the lab is actually important. We help establishing the diagnosis, aid in optimizing treatment regimens, and help to monitor the effect of treatment. And with that, I'd like to say thank you very, very much, and have a great day.